It's a pleasure to be here, and my topic today is actually something that's really important for all of us. I can tell you in our practice, probably in terms of implant dentistry, that extraction sockets and implant placement take up about 50% of the implants we place, or even more, are in extraction sockets. And what we're going to talk about today is a little bit about how we actually go about treatment planning, especially following what you just saw, talking about really saving and extracting teeth. It's also part of the process that we go through. This is a great case by Stefano Granata from Modena, Italy, that really shows some of the things that we go through and some of the challenges that all of us have to go into, especially in periodontal involvement, fractures, and endodontic failures. 2 class 3 furcations, severe periodontal defects back in the early 90s. And what I love about this case is how well documented it is and how really over a long term you're looking at. So this is 17 years later, 2010, after 2 root resections, standard crown and bridge dentistry, excellent periodontal maintenance, and lasted 17 years until the mesial root of the lower right second molar fractured. At that point in time, and only then, after 17 years, did Stefano go in and place an implant in that area. But take a look now, and this is what we're looking at. Making clinical decisions. Looking at teeth, knowing what you just saw and what we can do and what we've known we can do for a long time. And when do we actually extract? When do we place implants? When do we save the teeth? This implant's only 6 years old. This root here, 23 years, been maintained. Obviously, a lot of things go into it. The expertise, the maintenance, the patient, and also the clinician's risk tolerance. What are they willing to live with along with the patient in partnership? So that's what we're going to talk about. Extraction site management is a complex area. We manage it and deal with it and have a lot of challenges throughout our practice with fractures, endodontic failures, as you just saw, periodontal involvement, and trying to balance a lot of aspects. How do we make decisions? And we can do it in many ways and try to maximize our ability to find an aesthetic solution. As often as possible, try to do it in a minimally invasive approach. But the biggest critical factor, I think, that at least for us as our team and individuals and with our patients, is really managing risk. If you really need to see a common denominator in terms of extraction site management, it has to do with managing risk, and we'll talk a little bit about that. To develop a risk profile as an individual, what is your risk profile is probably different than the person sitting next to you. It's different from patient to patient. How you actually put it together and create a treatment plan that works for you and your patient is really the challenge. And there are controversies. You would think after more than 30 years of placing implants in extraction sockets that we would really have a unanimity in terms of our approach, but we don't. If you go to many lectures, if you read articles, you'll see probably half of the best academicians and clinicians in the world, half of them may tell you, never attempt an immediate implant. You'll see a great surgeon and educator tomorrow, Danny Buser from Switzerland, that for years have talked about really he never does immediate implant placement. Others always utilize implant placement. You'll see aspects of never raise a flap when you extract a tooth. Always raise a flap. Graft the gap is not necessary. Always graft the gap. How do we end up knowing this and figuring it out? How do you make a decision? When we come to these meetings and talk and discuss and you talk to your colleagues and you try to educate yourself about it and think in terms of an evidence-based approach, in fact, you'll see that a lot can be done to justify either of those positions. So how do you, as a clinician, when you see that patient on Monday morning, how do you make that decision? And my message to you is going to be that to use evidence-based methodology, but also do it on a personal basis that relates to your risk tolerance, the case in question. When we look at clinical options, These are pretty much, if you summarize it, has to do with early placement, which has been defined as 6 to 8 weeks, or delayed, which is 12 to 16 weeks after extraction. These are extractions and waiting, not grafting, not doing anything. You'll see Dr. Boozer tomorrow talk about that. That's the approach for managing it relative to allowing soft tissue healing, early placement, allowing bone healing, delayed placement, and then place the implant and graft, and you'll see a beautiful example of that tomorrow. Immediate implant placement. Extract, place the implant the same day. Staged approach. Graft, wait 6 months or more, and then place the implants. And orthodontic therapy, which you've also seen as well. These are options. Making decisions is the challenge for us. So let me take you through a few of the aspects that we try to look at it. I think the biggest problem when you really hear a lot of these definitive statements, the reason Maurice early today told you we never say always, we never say never, because each and every challenge is an individual challenge. When you look at these two cases, it's easy to think that you're going to treat them the same. For us, really, if our initial response, at least for me, I look at it, I say, sure, I'm going to extract these teeth and place an implant. It should be an immediate implant placement. That's the initial one. But we're not talking about the same type of case, and that's why we can't group everything together. In fact, when I really give you more information, that this particular case on the left has no labial plate, are the decisions still going to be the same? I don't think so. So we need to think that in this case on the right, your labial plate's intact, this one isn't. We're going to create different treatment plans. We're going to make different choices. And those are the challenges for us to really be more specific and unique in what we do. Try to compare apples to apples, not apples to oranges. We talk about everyone here can know that, that these are actually all fruits. But to really be wise about how you treat cases is to separate that. And no one would be able to put all of these in a fruit salad. So that's the real message in terms of figuring out and making decisions. We wouldn't treat the left side of the screen, that patient on the left, the same way that you treat the patient on the right when you extract these teeth. So in doing this and looking at it, very early on we knew that to be able to create an acceptable treatment plan, we actually had to go ahead and classify our sites. And we first published this in 1993, talking about classification of sites from ideal to moderate defects to severe defects in the extraction sockets. Yes, we can create excellent aesthetics around implant restorations, but we also have failures. The question is how to minimize those failures, how to mitigate the risks involved in treatment. So when we look at these cases, and we're working with Dennis Starnow and Stephen Chu, as well as other teams, we came up and published on the concept of the dual zone of extraction site management. And what we try to do here is to really look at the site, classify it, and almost segregate it. Look at the challenge and segregate them in a different environment. And what we did is look at the bone zone separate from the soft tissue zone. Bone zone is from the crest of bone apically, and the soft tissue from the crest of bone to the height of the gingival margin. Different challenges, different solutions that we need to put together. Let's take a look at a case as you see here, where we term as a class 1 relationship. The first thing I look at is where's the labial plate of bone? Critical concept and critical piece of information that all of us need to make an appropriate decision. Why is this so critical? This is the bone zone. We want to know the integrity of the labial plate. How thick is it? How thin is it? And when we look at the literature and think about evidence base, what you'll see is that most of the literature out over the last 7, 8 years, especially based on CBCT technology, 90% of patients had a missing or thin labial crest of bone. 90%. We used to associate thick periodontium with thick bone. It's not true. Most labial plates in the anterior region are quite thin. In fact, 50% are equal to or less than 0.5 millimeter. Therefore, we have to include it as part of our treatment plan. So one of the first things we do, we go in, we take a look at the labial plate. We then go to the soft tissue zone. We want to know how thick that tissue is. Critical information. Where is the interproximal bone on the teeth adjacent to that site? Once you collect all that information, you can make a determination about how you're going to approach this. Are you going to extract this tooth and wait 6 to 8 weeks for early healing, or 3 to 4 months for late healing, and then place the implant? You would be taking away the appropriateness of really working in a pristine site. You may lose that labial plate in all likelihood. So under these conditions, for us, this is a perfect example of where you would want to place an immediate implant. And in fact, this is a protocol. These are evidence-based strategy today that you'll see in the literature. It's been written about, it's proven. Implant size and position is based on very, very critical factors. We use narrower diameter implants to stay away from the labial plate, not to actually stress that labial plate. We can plan this out really well. More lingual placement, hugging the palatal wall, utilizing that triangle of bone concept from Scott Gans that you'll see later after the break. Purposely create a gap of 1 to 2 millimeters so that you know when you're done, you can utilize a graft that is slow resorbing, that has low turnover, that will actually create a solid foundation for the soft tissue. So all of these aspects, and placing the implant 0.5 millimeter below the bone crest, will give you an evidence-based approach to maintain the bone, the soft tissue, and achieve long-term results. Guided surgery for precision, to allow us to really place that implant where we need to do. Place the implant and then place our abutment the same day, as you saw with Dr. Romanos earlier. One abutment, one time concept, try to solidify the area. The provisional is placed, really manage the contour, and that day is usually straight or concave on the day of surgery, and very often under-contoured as it relates subgingivally below, to the adjacent tooth. These are all factors that we know we have evidence for and can manage a type 1 site, an ideal site, in a very predictable fashion. The temporary in place, here it is at 10 weeks, very stable, even with a very high smile line with scallop tissue, we're able to maintain it. And eventually moving on to cementation and maintenance of all the architecture for a very, very challenging high smile line kind of patient. The aspect, though, is in these critical cases, they're not all the same. Even when you have good labial plate of bone, even when you have good gingival margin position, here's a fractured tooth. It's a case done by Ashraf Suya from Tunisia, and really shows us and expresses a little bit of the challenges that not all cases are the same, not extraction sites. So you have premolars. Usually I would look at these, yeah, we'll extract and put implants. But you have roots that go into the sinus. You'll not be able to go beyond the sinus in order to achieve bone integrity and primary stability. So what's done here is, in fact, is a combination of extraction, sinus lift, and immediate implant placement. So still immediate implant placement, but we have to factor in the other concepts, the other risk factors involved. How much can we control these? And in fact, this is done quite nicely. This is utilizing the AnyRidge implant from Megagen. And Ashraf does the sinus lift, grafts around the gap, and is able to get primary stability and a very, very nice result. To be able to integrate different concepts from advanced, as far as the sinus lift is concerned, to standard management of the extraction socket. And an integration, as you see here. So not all approaches would be the same. In fact, today when we have aspects of digital technology, we're able to really add even more efficiency into the system as well as accuracy. Here's a central incisor with a failing endodontic treatment that's been retreated a few times. The tooth is going to be extracted. Standard planning that we utilize, digital technology, CBCT, to achieve our planning aspect, implant position. But today we also can add restorative planning that actually merges together with the surgical planning to be able to create on the first day of treatment all the concepts and pieces that you need to put together. We can merge STL files with the DICOM plan in order to add the restorative component of this treatment. You can also superimpose it on the patient's smile line so that when the laboratory receives this information, they can actually plan out and see where the lip line is. And as we move forward, this will not only be two-dimensional, it will be three-dimensional in nature. And we can accurately relay that information and utilize it, as we did here, utilizing Materialize and the Atlantis laboratory to be able to fabricate pre-operatively, pre-surgically, an abutment and a temporary restoration. So on the day of surgery, you know what implant you're utilizing, size, length, width. You'll have your final abutment as well as a temporary restoration. And they all come in a little package, and then go through the process as you normally would. Atraumatic extraction, precision placement of the implant, and then attach your ceramic abutment, graft the gap, place your abutment as well as your temporary, allowing us to really create the planning, the accuracy, the precision in terms of both the surgical application of the technique as well as the restorative application. Of course, the temporaries are out of occlusion, both in centric and excursive movements. And when we look at the planning phase, this was the plan, this is the application. We really are able to connect them and create something that's evidence-based, that is reproducible and maintainable over a period of time. This is the case I showed you earlier. What do we need to do? We just saw type 1 sites where you have an intact labial plate. You had good bone zone, good soft tissue zone. In this case, we have good soft tissue, but in fact, the underlying osseous is compromised, at least on the labial plate. So we do a full thickness flap. We take a look. We have good interproximal bone. So this is a moderate defect. We call it a type 2. It's a predominantly labial defect. We're very good at taking care of labial defect and reconstructive dentistry. So we're going to look at now the dehiscence. It's a narrow dehiscence, and we're able to actually place the implant within the bony confines or within the alveolus. So we go ahead and place the implant immediately. Look at how narrow this is. So still immediate implant placement combined with guided bone regeneration at the day of surgery. A bone graft is placed, a resorbable membrane is tacked on. We utilize PRGF fibrin membranes. And sometimes if the tissue is thin, we'd also add a connective tissue graft. Get our closure. Later on, we punch through and expose the implant. And again, this approach is also evidence-based, and you'll see different applications of it over the next couple of days. The key, of course, is integrating it and matching the experience, the risk profile for the clinician as well as the patient. But the criteria for success, as you saw earlier today, the endpoints are really the same for all of us. Whether you do early, delayed, immediate stage or whatever, the endpoint is periodontal health, the aesthetics, as well as the ability to maintain these results over a long period of time. Healthy tissue, color balance, and of course the integrity of both the bone zone and the soft tissue zone, the dual zone application of extraction site management. Our last case takes a look at a situation where we have a fracture of a right central incisor with a fistula. And what we're going to do is really take a look at how almost, maybe not even as damaged, a labial plate as the previous case. In the previous case, we did immediate implant placement. So you see a case here looking at, should we do minimally invasive as well and do immediate placement, or should we do a staged approach? If we did immediate in the previous case, why shouldn't we do immediate in this case? It's not the same patient. It's not maybe the same criteria. It's not the same soft tissue. Previous patient had thick tissue. Thick tissue allows us to be a little bit more aggressive, to do more immediate placement types cases. When we look at this particular case and look at the risk profile for us here, both as clinicians, the risk profile for our surgical techniques that we're applying, as well as patient that we're treating, sometimes you may go to a more aggressive approach. Sometimes you go to a more conservative approach. This is another one of the factors in clinical exam, patient exam forms that we utilize. It's one that we adapted in a way from ideas that John Kois talks about. Look at the application of the patient, the diagnosis, and try to form in your mind a risk profile for the treatment that you're choosing that conforms to your ability to deliver it, to the procedure and the techniques that you're going to utilize. It starts out by looking at what kind of case are you working on, a single or adjacent implants, completely different type of animal. It looks at analysis of the space provided for the restorative recipient site, tooth proportion and occlusion. Sometimes wax-ups are involved, sometimes 2D smile design aspects and imaging are included. It looks also at the gingival tissue assessment, lip dynamics, whether you have a labial plate, interproximal bone. Overall classification, type 1, type 2, type 3, and you see it's in green, in yellow, and in red. Do you want to treat cases in the red zone? I'm always better in the green zone, to be honest with you. Biotype, scallop form, flat, high, but in implant dentistry, really the thing that works the most for us, thick versus thin, green and red. It's a red flag. It makes you take a step, take a breath, and try to figure out what's the best approach. For this case, when we look at this case, and these are the three really first components that we look at: facial bone, interproximal bone height, and biotype. Facial bone is actually intact, but it's compromised slightly because of a slight fenestration because of the fistula that's from the fracture. And the biotype is thin. So when we look at all these aspects, thin biotype, high lip line, demanding patient with high expectations, seeking the lower risk profile, and a questionable labial plate. You put all of those together and you actually will go, at least I would go, to a more conservative approach. What's a more conservative approach? Basically going to a staged approach. I'm going to go in, the tooth is going to be extracted, and it's going to be grafted with an internal resorbable membrane against the labial plate, a bone graft and a connective tissue graft over the top of it. No implant. The area is allowed to heal, and then you come back and you're able to place the implant through the tissue, narrow, healing abutment so you don't stress the soft tissue, and at a later date, once it's integrated through several laboratory procedures, this case was done with Christian Coachman, the tissue can be shaped and we can create a better profile that matches the adjacent teeth and all the dynamics that's actually required and demanded in a particular case like this. So when we try to put all of this together, and you really look at the next couple of days and look at the different speakers and look at what's presented, the takeaway message that I hope you really take away not only from my presentation but from all of the presentations that are in front of you, what is evidence-based about what was presented, what treatment was done, what are your options, whether it's early, delayed, immediate, staged, orthodontics or others. But most of all, classify the site. Know what type of site you're working on. Is it a type 1, a type 2, a type 3? Do you have a labial plate? Do you have interproximal bone on the adjacent teeth? And manage the risk not based on some arbitrary factor, based on what your experience is, your expectations of particular modalities of therapy, what you're willing to live with in terms of something going wrong, and certainly what the patient's willing to live with. A lot of what we do is really what Maurice told you. We really learn a lot from you, and just like crowdsourcing is all about it, Dental XP and these meetings are all about crowd learning, not just in the auditorium, but also outside. I thank you very much for your attention, and I look forward to the rest of the next couple of days. Thank you.